PGD is pre-implantation genetic diagnosis, and a good example of a genetic defect that would benefit from PGD is the screening of thalassemia. If both partners have thalassemia, or if they're carriers of the thalassemia defect, there is a 1 in 4 chance that the child that they have will have thalassemia major, and that can be quite catastrophic. Therefore, it would make sense to screen the embryo for thalassemia before it is transferred, and that would prevent the possibility of a baby being born with thalassemia major. There are many other genetic defects which would also benefit from screening utilizing pre-implantation genetic diagnosis. The key difference between PGD, pre-implantation genetic diagnosis, and PGS, which is pre-implantation genetic screening, is that in PGS you are screening all the chromosomes for either a loss or gain of either a chromosome or a part of a chromosome, whereas in PGD you need to know the specific defect that you're looking for. Conventionally, if doing PGD, once you knew the genetic defect that you were looking for, the lab then has to source for the probe that can be utilized to search for the genetic defect within the embryo. If it was a common disorder, then the probe would be easily found. If it was an uncommon disorder, the probe has to be sourced for in other countries. That can sometimes be difficult and it can take time. Today, we have new technology that can be used to do PGD. That new technology is called carrier mapping. So what is carrier mapping? Carrier mapping is a new technology that makes PGD more efficient and more sensitive. Instead of using a probe to look for the genetic defect that we are looking for, we use the genetic material from the partners as well as from the index sibling who may have the disorder, and use this information to map out the genetics of the embryo and therefore identify the defect more reliably. It doesn't require a probe anymore and is also more sensitive. We are also often asked what the potential drawbacks are of doing pre-implantation genetic testing, either PGS or PGD. If a couple want to do pre-implantation genetic diagnosis, obviously there is a specific genetic defect that they're looking for, and therefore we may not have a choice. There may not be an option of not doing PGD. For pre-implantation genetic screening, the equation can sometimes be a little bit more complex. Certainly there are some patients who will need PGS, and there are some patients out there who may benefit from PGS, and perhaps there may be some couples out there who may not require PGS. Who are those who will require PGS? These are patients who have either had difficulty in conceiving and then went on to conceive and had recurrent miscarriages. The other group of patients may be patients who have had repeated cycles of IVF and despite putting back high quality embryos into the womb, fail to conceive. Many of these women are labelled as having recurrent implantation failure, and one of the main reasons for recurrent implantation failure, perhaps not the only reason, but the main reasons for recurrent implantation failure is the genetics of the embryo. The suspicion that despite being able to produce embryos that look good, the genetics of the embryo may not be, and they may benefit from PGS. Similarly, you may have patients who are older and who are concerned that the embryos that they produce may be carrying genetic defects like Down syndrome, and therefore transferring these embryos may result in them becoming pregnant with an embryo or with a fetus that is genetically abnormal, and therefore put them in a very difficult situation of having to consider things like termination of pregnancy. So perhaps if these older women had their embryos screened before transfer, then they may avoid a pregnancy with such an abnormality. But if you had a patient who was younger and who is trying IVF for the first time, then perhaps PGS may not be a good choice, simply because it is an intervention and it's not cheap. Patients such as this may find that just putting back the embryos without doing PGS may be more cost effective, although perhaps slightly less efficient. As far as PGD is concerned, without knowing what the specific genetic abnormality is, PGD will not be possible. A good example will be a couple that come to see us and describe something that sounds like a genetic abnormality that is clearly running in the family and want us to screen for that abnormality. We are unable to until and unless they are able to identify what exactly is the genetic abnormality that seems to be running in that family tree. So in conclusion, pre-implantation genetic testing is divided into pre-implantation genetic screening and pre-implantation genetic diagnosis. Pre-implantation genetic screening makes IVF more efficient, it reduces the time to pregnancy, and it avoids transferring embryos which have known genetic abnormalities and therefore reduces the risk of miscarriages. PGD, on the other hand, requires you to know the specific genetic abnormality that you're looking for, with the sole intention of identifying the embryos that are carrying that particular abnormality and excluding that embryo for transfer. And the new technology that is available for PGD, which is called carrier mapping, makes PGD more efficient and easier and more accurate.